Welcome to Endophenotypes, Evidence, and Long-Term Outcomes in Moderate to Severe Atopic Dermatitis Management, a Decision Library. I'm Professor Jonathan Silverberg. I'm Director of Clinical Research and Patch Testing at the George Washington University School of Medicine and Health Sciences in Washington, D.C. These are the faculty disclosures, and these are the learning objectives for the program. Right. Let's get started now with Module 3, Long-Term Maintenance in Atopic Dermatitis. All right, so for background, it's just important to recognize that, we talk about things like moderate to severe, mild to moderate, as if patients are always stably in those categories. But there's nothing farther from the truth in this disease. It is a very unstable and hypervariable disease, and patients can be bouncing around all the time. They may always have some degree of activity, but there's times when they're severe and then there's times when they're mild and everything in between. And so we have to recognize that when you look at this up and down, it kind of reminds you of a roller coaster. And for many patients, they'll actually describe the course of their disease as a roller coaster. We need to not only treat those flares and bring them down, but we need to also work on flare prevention and proactively preventing flares as much as possible in order to stabilize the disease. Now, our goals for management should include promoting daily practice of skincare, avoiding triggers, treating and preventing flares. Why? Because we want to stabilize the disease. Trigger avoidance and daily skincare have been shown to be effective at preventing flares. We want to improve the skin barrier, improve quality of life. We want to, of course, integrate patients into that shared decision-making process. But all of this is within the context of trying to achieve long-term control and not just quick fixes. This is the framework from the atopic dermatitis yardstick that really addresses not only the need for acute treatment in terms of applying TCS or taking some systemic therapy to shut a flare down, but integrating all of these different approaches into the maintenance therapy to try to stabilize the disease and prevent flare-ups. Now, in terms of systemic therapies for moderate to severe disease, we've had a lot of stuff that we used to use in the old days before we had approved agents for atopic dermatitis. But they're all oral immunosuppressants with brutal safety profiles. If you look at the labels on these drugs, they make you cringe. They're not approved for atopic dermatitis. They're all considered off-label. They have variable efficacy, variable dosing, not the greatest of tolerability, some serious adverse events that come up that are life-threatening. And so these are very complicated drugs that were almost never used because of the complexity of the safety profiles that come up. When we think about, cyclosporin in particular was the one that was shown to have the best efficacy data in the olden days of atopic dermatitis management, but boy, it is not clean. And the FDA's recommendation is to have patients not be on it for more than a year. I generally try to keep them no more than 6 months, because if I aim for 6, at least I'll get them off before a year. In Europe, it is approved officially for the treatment of atopic dermatitis, and some patients are on it for longer, but we see that the drug survival rates for these drugs are really poor because of tolerability concerns and high rates of adverse events, poor efficacy that comes up, so not the ideal option. Now we've got newer therapies, thankfully. And in Module 3, we talked already a lot about, dupilumab and tralokinumab and these newer agents, just at a high level to thinking about some of the real-world-esque data. We have data now for the open-label extension data pushing out 3 years, now actually out to 4 years for dupilumab. Here I'm showing you data out to week 204, showing overall 90% reductions in the eczema and severity index, 69% reductions in the itch scores, good efficacy even after switching therapies in the real-world data as well, showing that patients are able to hit many different treatment targets from the different treat-to-target guidelines that were recently published out of Europe. And so really showing in a real-world-like scenario, patients are doing quite well. Now, similarly, when we look at the efficacy of dupilumab in adolescents from the open-label extension, we also see high rates of efficacy out at week 52, relatively speaking, low rates of adverse events, no new safety signals that emerged beyond week 16 out to week 52 and beyond. And these studies are ongoing, and hopefully we'll see even more reassuring long-term data down the road. Now, when we look at the efficacy of upadacitinib as an oral JAK1 inhibitor for moderate to severe atopic dermatitis, now approved for adolescents and adults in the United States, we see overall good maintenance of response out between week 16 and week 52 in combination with topical corticosteroids, or even in terms of monotherapy as well. But we're seeing overall good results that come up for itch, for IgA clearance, for EASI-75s, etc. And no new safety risks that were observed in that longer term period. Those studies are ongoing, and we should see even more data soon in terms of year 2, year 3, etc. Now, in terms of the long-term efficacy amongst those who were already responders amongst baricitinib. So the interesting thing about baricitinib is it's shown a lower efficacy profile, even at the 4 milligram dose, compared to what we saw with abrocitinib and upadacitinib, albeit we don't have head-to-head data, but we do have between trial comparisons. It appears to be a little bit weaker. However, those patients who do respond by week 16, whether it's with the 2 milligram dose, whether the 4 milligram dose, when they are maintained on the drug, they tend to have high rates of maintenance of response. And that is an important consideration if you are using baricitinib, whether it's on label in those regions where it's approved or off label in those regions where it may not be approved. For abrocitinib as well, we have 24 and 48 week safety data now from long-term extensions. We have integrated safety analyses. And overall, the event rates for the serious or life-threatening adverse events are low, but not zero either. The good news is they appear to be really not much higher or similar to what was observed previously in real-world data in terms of just the baseline level of risk amongst atopic dermatitis patients. But it's something that we definitely have to keep in mind, that everything that was observed with tofacitinib and rheumatoid arthritis has at least happened with rare events, ends of 1 or 2, in abrocitinib and upadacitinib. So it's not zero, but fortunately it does not appear to be as common as the adverse event rates that were seen with tofacitinib in rheumatoid arthritis, etc. And with that, I thank you for your attention. I would like to thank Sanofi and Regeneron Pharmaceuticals for their support of this important educational activity. Please remember to complete the post-test at the end of the session to secure your CME credits. And stay tuned for the next session titled Accessing Care, Setting, and Maintaining Goals for Eczema, a panel discussion between clinicians and patients. My name is Dr. Jonathan Silverberg. Thank you for joining us.